हेलो नमस्ते मेरो नाम ओम म चाहिँ एलएमसीमा फाइनल इयरमा पढ्दैछु अनि आजको सेसनको लागि चाहिँ जगदम्बा दिदी लाई धेरै धेरै धन्यवाद हामीहरूलाई इन्भाइट गर्नुभएको छ। डाक्टर अनन्त पनि हुनुहुन्छ आज। डाक्टर अनन्त चाहिँ युएसमा रिमेटोलोजिस्ट को रूपमा काम गर्दै हुनुहुन्छ अनि उहाँले चाहिँ आज रिमेटोइड आर्थराइटिसको बारेमा भन्ने भनेर भन्नुभएको छ।
Now I'm going back. This is our learning objective for today. So we'll discuss on the basic immunology of rheumatoid arthritis. We'll discuss some of the basic pathophysiology of rheumatoid arthritis, and we'll wrap up the session today on clinical manifestation. I'll discuss more of the common clinical manifestations of rheumatoid arthritis in the upcoming lecture. I'll discuss more on some of the complications or extra-articular manifestation of rheumatoid arthritis. That's the topic for next lecture. Now, when we talk about rheumatoid arthritis, it's always very important to understand the basic concepts and how we define rheumatoid arthritis. Now, as we have discussed in the first couple of lectures, we categorize arthritis into two basic categories. One is called inflammatory arthritis, and other we call non-inflammatory arthritis. Now, I have stressed this concept in the beginning. It's very important. When you see a patient with joint pain, it's always important to categorize into these two boxes, because that will help you formulate your differential diagnosis. The rheumatoid arthritis belongs to the inflammatory form of arthritis. And in particular, rheumatoid arthritis is considered a polyarticular inflammatory arthritis, basically meaning it involves multiple joints. Now, if you look at the definition of a polyarticular inflammatory arthritis, the textbook definition is you have to have at least more than 5 joints involved. 4 to 5, that's a typical definition. If you have more than 4 to 5, then we call it a polyarticular arthritis. And rheumatoid arthritis is one of the differential diagnoses in the polyarticular inflammatory arthritis. Now, some of the other common differential diagnoses, we also think like psoriatic arthritis, spondyloarthritis, reactive arthritis, and even viral arthritis. Those are some of the other common differential diagnoses. Now, we'll focus more on rheumatoid arthritis today. So by definition, it is a chronic, is a symmetric, and is an inflammatory arthritis of autoimmune etiology. Now, we'll go over all of those points in the further details. So chronic, by definition, if you look at the textbook definition, it has to be more than 3 months. Now, this is more for a textbook definition or more for a research purpose, but clinically, sometimes we do not need to even wait for 3 months before we make the diagnosis of rheumatoid arthritis. But by definition, it has to be chronic for more than 3 months. Now, the other key concept in rheumatoid arthritis, it has to be symmetric, particularly meaning it has to involve both sides of your body. It could be your hand or the feet or other joints. So it's typically symmetric fashion involving both sides of the body. Now, it has to be inflammatory. And then the way we describe inflammation is when you examine the joint of a patient, we describe this as synovitis. Now, some of the key features of synovitis include when you ask the patient, they will describe a significant morning stiffness. Typically, the stiffness lasts for more than an hour, and then usually pain improves with activity. If we think of non-inflammatory arthritis like osteoarthritis, patients do complain of stiffness in the morning, but usually typically it doesn't last long. Typically, it's less than 30 minutes. But as compared to rheumatoid arthritis, they typically describe multiple hours of morning stiffness. And the next important clinical sign of synovitis is signs of inflammation that include swelling, warmth, and limited range of motion. Now, when we do blood work to further investigate, typically most of the patients will have elevated inflammatory markers, either CRP or ESR. So these are the 3 important features which we call synovitis, including clinical symptoms of morning stiffness lasting for 1 hour, pain improves with activity, and then significant swelling and limited joint motion in your examination. And that is supported like in the lab by high ESR and CRP. Now, in the next key concept, it is an autoimmune etiology, meaning there has to be presence of autoantibodies. Now, in most cases of rheumatoid arthritis, almost more than 80%, there will be presence of either rheumatoid factor or CCP. There is a rare variety of rheumatoid arthritis, which we call as seronegative, meaning some of those patients, like around 15 to 20%, they may not have rheumatoid factor or CCP, but they will have other clinical symptoms and signs. Either they have more than 3 months inflammatory arthritis, and when you examine the joints, you will see signs of synovitis. So in that category, we call them seronegative rheumatoid arthritis. But typically, most of the patient will have some signs of autoimmunity as evidenced by presence of rheumatoid factor or anti-CCP. Now, some people also call this ACPA, and the full form is anti-citrullinated peptide antibodies, and that is a marker of autoimmunity. Now, when we talk about more about rheumatoid arthritis, it's always important to describe what is the pathology, what is the problem. Let me move this to this side. So this is a picture depicting a like normal synovial joint. If you look at the joint, you have two bones that come together, and the yellow is the cartilage. Now, if you look at details, the blue is denoting synovium. Normally, there is a thin lining of synovium that lines both the surfaces of a synovial joint. And the primary problem in osteoarthritis is the synovium. And typically, there is significant synovial proliferation. Normally, the synovium is 1 to 2 lining of a tissue. But in case of rheumatoid arthritis, this synovium is hypertrophied, and there is a thickening of the synovium. Now, in pathology, you might have heard the term pannus formation, and that's basically what it is a proliferation and inflammation within the synovium. So that is the primary problem. The primary problem is not in the cartilage or the bones. The primary problem starts in the synovium. And basically, there is synovial proliferation because of inflammation. And typically, the synovium then invades into the bone, the cartilage, and the ligaments. And that leads to the other problem in rheumatoid arthritis. Like we have swelling because of extra fluid formation from the synovium. There is cartilage destruction, and there is also deformity of the joint. That is because of the invasion by the synovium. So key concept to remember in the pathology is the primary problem in rheumatoid arthritis is not in the cartilage. It's primarily in the synovium, and the primary problem is because of inflammation. The synovium is hypertrophy, and that leads to invasion of the bone and the cartilage. Now, when we talk about the pathophysiology of rheumatoid arthritis, these are the key risk factors that are known so far, and we consider rheumatoid arthritis as a multifactorial disease, meaning you have an interaction between genes and the environment. Now, some of the common genetic risk factors that are considered include SLA-DR4 and SLA-DR1. So these are some of the genetic markers of rheumatoid arthritis, and these genetic risks usually account for almost 60% of the risk. Now, I highlighted only a couple of genes that are implicated to increase your risk of rheumatoid arthritis, but there are multiple others. These are just a few of those that are well characterized to increase the risk of rheumatoid arthritis. Now, all of these genes are particularly involved in how our body processes the antigens, like the SLA-DR4, SLA-DR1. Those are particularly genes in what we call the MHC, the major histocompatibility complex, and they are basically involved in antigen presentation. And because of genetic mutation in those particular areas, there is increased risk of rheumatoid arthritis. Now, the way we understand what is the role of genes in rheumatoid arthritis is based on twin studies, because they share almost 50% of the genes. And now, when we look at the twin studies, we call concordance rate, meaning if a twin have rheumatoid arthritis, what is the risk of having other twin? What is the risk of other twin having rheumatoid arthritis? The risk is around 12 to 15%. So it's not very high. So that suggests that it's not just a gene, but there are multiple other environmental factors that are also important in causing rheumatoid arthritis. So gene is one of the factors, but it's not just a genetic risk. There has to be multiple environmental risk factors that need to come into play to cause rheumatoid arthritis. Now, there is still a lot of debate and there is still lack of understanding on what are those environmental risk factors. Now, these are the three that are most commonly known to increase the risk of rheumatoid arthritis. Now, first one is smoking. Smoking is a very strong risk factor, particularly for seropositive rheumatoid arthritis. Now, the thought process is smoking, I think, caused some change in the protein modification. Like particularly, there is a concept of citrullination. Now, we talk about the ACPA, the anti-citrullinated peptide. So that's a protein that is modified by smoking and some other environmental factors. When protein modification happens, our body produces antibodies against those modified proteins. And that is what starts the process of rheumatoid arthritis. So any of those environmental risk factors, what they primarily do is they modify our own protein. And basically the citrullination is one of the protein modifications. And that modification is what starts the autoimmune process. Either smoking could also cause that. And then there is also an important role of microbiome. Now, microbiome is basically the collection of all the bacteria that are present in our gut, in our skin, or in the mouth. Normally, we have a lot of normal flora in the mouth, in the gut, or the skin. Now, people who have rheumatoid arthritis, they tend to have a different type of microbiome. Now, this is an area of still ongoing research to connect between microbiome and then the rheumatoid arthritis. But the basic research, particularly the mouse model studies, has shown that there is important role of microbiome with the genetic, with the risk factor for rheumatoid arthritis. Now, the infection is still a topic that is still debatable, but there is a thought that various types of infection, either bacterial or viral, could start the process of rheumatoid arthritis. But this area is still quite debatable and unknown, but there has been some good studies showing that there is some link between infection and then the risk of rheumatoid arthritis. Now, overall, the key takeaway from this slide is rheumatoid arthritis is a multifactorial problem where the gene has to interact with the environmental risk factors. And having a family history of rheumatoid arthritis doesn't always mean you are at high risk of rheumatoid arthritis. You have to have certain environmental risk that increase your risk. And most important to remember is smoking. So that's why if you have a patient who has rheumatoid arthritis or we have family history of rheumatoid arthritis, you can tell them that one of the ways you could reduce your risk of rheumatoid arthritis is stop smoking. I think that is one of the key concepts that you should focus to your patient, that smoking cessation is very important to reduce your risk of rheumatoid arthritis. And also, smoking does increase the risk of having severe severe rheumatoid arthritis. And people who tend to smoke, if they have rheumatoid arthritis, they tend to have more severe disease. Now, talking more detail on how rheumatoid arthritis starts, there is a concept called initiation. And if you look at the slide on your right, you will see a busy graph. And what basically it's showing is it's showing different component of the joint tissue. Like you see like fibrinogen, you see histone, you see the other is the enolase. Those are different components of joint tissue. Now, if you look at the x-axis, so the x-axis is showing days related to the RA diagnosis. So 0 is the day when somebody gets a diagnosis of rheumatoid arthritis. Now, if you go forward, this is days after diagnosis of rheumatoid arthritis. And if you go backward, these are the time before the diagnosis of rheumatoid arthritis. Now, if you look at the graph, you could see that patient who gets the diagnosis of rheumatoid arthritis day 0, they start producing autoantibodies way before they get the diagnosis, meaning almost 4,000 days before the diagnosis of rheumatoid arthritis. So that means that you first produce autoantibodies. That's the initiation of the rheumatoid arthritis etiology. You start producing autoantibodies, and then down the road, the level of autoantibodies gradually increase. And then at some point, when you have the right environmental trigger, then you have rheumatoid arthritis. Then you have the clinical sign and symptoms of rheumatoid arthritis. So that's why the important thing to remember is rheumatoid arthritis start with production of autoantibodies, either rheumatoid factor or CCP, and these antibodies could be against different component of your joint tissues. Now, right now, we just check antibodies against the CCP. There are ways we could also check this, but this is more for research purpose. We don't normally check all of those antibodies, but for research purpose, we do check some of those other autoantibodies. But for clinical purpose, anti-CCP and the rheumatoid factor are the two most commonly used autoantibodies. Now, what happens after you start making autoantibodies? These autoantibodies recognize the joint tissues like collagen. And when they recognize those tissues, they attack those tissues and they start making an antigen antibody complex. And this antigen antibody complex, which initiates the process of inflammation. And this antigen antibody complex, they attract other cells of immune system, like they attract macrophages, they attack B cells, T cells, and that cause further inflammation, causing all of the symptoms of rheumatoid arthritis. Now, we'll briefly discuss some of the key immune cells that are involved in rheumatoid arthritis. Now, why is this important? When we talk about treatment, if you understand what are the key drivers or key cells involved in rheumatoid arthritis, we use medication focusing on those key tissues or key players of immune system. Now, we'll talk about treatment later, but if we look at the treatment options, some of the medication they target T cells, some of them they target B cells, and some of them target cytokines. So we'll talk more detail when we talk about the medication, but it's important to understand what are the key players or the key immune cells that are involved in rheumatoid arthritis. Now, in immunology, we talk about two branches of our immune system. One was called innate immune system. And some of the key players in the innate immune system include macrophages, mast cells, and dendritic cells. So these are the cells that are important in rheumatoid arthritis pathogenesis. And in adaptive arm, the T cells and the B cells are the most important players. Now, there are a few other cells that are beyond this innate and adaptive immunity that include fibroblasts and chondrocytes. These are the normal cells that are present in a joint. And fibroblasts are within the tissue of the synovium, and the chondrocytes are also within the joint tissue. So these are the other important cells that are important in pathogenesis of rheumatoid arthritis. Now, other problem that happens in rheumatoid arthritis is because of autoimmunity, there is altered cytokine level. Now, you might have heard the cytokine, they are basically chemical messengers that are produced by different immune cells like macrophages, mast cells, T cells, and B cells. All of those produce different type of cytokine. And the primary role of cytokine is they are the messengers. When you have inflammation, the cytokines either signal increasing inflammation or they signal decreasing the inflammation. So they are like signals for communication. All right. Now, some of the key cytokines that are altered in rheumatoid arthritis include either TNF, the tumor necrosis factor, or it could be IL-6. I just placed those two because those are the two targets during the treatment of rheumatoid arthritis. We have medication that targets TNF, and they are commonly called anti-TNF medications. Some of the common examples include Enbrel, Humira, Remicade. Those are some of the medications we'll discuss further later in the lecture, but they target TNF molecule. They usually block the function of TNF, and that helps reduce the sign and symptoms of rheumatoid arthritis. And other key cytokine is the IL-6, also called interleukin-6, and we have medication to block that interleukin, and that helps control the rheumatoid arthritis. Now, because of those alterations within the cells, intracellularly, there is also different cellular changes. And one of the key concepts, what we call signal transduction. If you have read in your cell biology, there is a lot of intracellular signaling happening after a cytokine attached to a receptor. And there is a molecule called JAK. They are basically intracellular enzymes, and that helps in signaling. Now, I know this is a little bit difficult concept to remember, but the JAK, you can just remember of the JAK as the enzymes that cause intracellular signaling. And there is a class of medication we call JAK inhibitors, also called Janus kinase inhibitors, and they are also one of the key options for treatment of rheumatoid arthritis. Now, these are the basically newer medication in the market in the last 5 to 10 years, and they have been very effective in controlling rheumatoid arthritis. So basically, you have innate immune cells, adaptive immune cells, and altered cytokines, and then altered intracellular signaling. That all together leads to rheumatoid arthritis. And basic concept is all of them, the final end product is increased inflammation. Either through cells or cytokines or the intracellular signaling, basically they upregulate or increase the immune function and causing signs of inflammation in rheumatoid arthritis. Now, this is a picture that describes what we just discussed. Now, I'll just quickly summarize. Now, we discussed that you have to have a genetic risk factors that include SLA-DR, PTP, and 22. This is one of the gene, and then the PADI. Those are some of the genes that are involved. I don't think you have to remember all of them, but if you could remember actually the SLA-DR, that is, I think, sometimes tested in your board. That is one of the risk factor, genetic risk factor of rheumatoid arthritis. So you have to have a genetic background with these genetic changes and in the right environmental context. And that could be a pathogen, infection, smoking. Those are the two known environmental triggers that start the process of rheumatoid arthritis. We call initiation phase. And what they do is they cause protein modification. Normally we have a lot of protein, but because of this genetic risk factor and then environmental trigger, they cause protein modification. And two of the most common type of protein modification include citrullation or carbamylation. Those are the type of modification of protein. And when this happens, our immune system is activated, like the innate immunity, that's macrophage. The M is for, this is for macrophage, and this is a fibroblast-like synoviocyte. It's one of the tissue in the joint. And this is the dendritic cells. So these are the cells of immune system or innate immune system. Now, when there's protein modification, the cells of immune system get activated and they cause inflammation. And what they do is they migrate to the central lymphoid organ. Now, when these cells, they recognize these new antigens in the joint, they capture those antigens and they bring to those lymph nodes. And the lymph node is where, now the dendritic cell is also called an antigen presenting cell. And the name itself suggests they present antigens to the T cells, and the T stands for the T cells. So the dendritic cell present the antigen that is a protein modified, and they present to the T cells, and the T cells, what they signal to the B cells is to produce antibodies. And that is how the antibodies are made. The antigen is presented to the T cells, and the T cells also signal to the B cells, and the B cells start making antibodies. Now, when there's a lot of antibodies, these are also called autoantibodies, and ACPA, the anti-citrullinated peptide, is one of those autoantibodies. And these autoantibodies, they go back to the joint and they cause inflammation. Now, if you look at there is a concept called second hit. Now, you might have heard this concept of second hit in oncology too. So you could, when you develop cancer, you have to have a genetic risk factors. And when there is another hit, other environmental risk factor, like when you are sun exposed or there is something chemical that is exposure. So that is the second hit that lead to development of cancer. So similar concept in rheumatoid arthritis is you have to have certain genetic risk factors and you have to have a second hit that is environmental risk factor. And when those two things come together, then you are at increased risk of rheumatoid arthritis. So it's a gene-environment interaction that is also seen in oncology and also seen in rheumatology too. Now, you could, if you see all the concepts like we talk about, there might be a role of complement fixation. Basically, what they are doing is increasing the inflammation in the joint. Now, let's switch the gear to some of the clinical manifestation of rheumatoid arthritis. Now, as I mentioned in the first slide, it is a symmetric inflammatory arthritis, meaning you have inflammation involving your both hand, it could be both feet, both shoulders, or the other joints in symmetric fashion. And it has to be polyarticular, and predominantly it affects the small joints. It could be in the hand joint. And the most typical symptom is most of the time the MCP, the middle part of your knuckle, the MCP and the PIP. That's the most typical. And the wrist is also very common joint that is affected in rheumatoid arthritis. One of the key is rheumatoid arthritis never affect your DIP joint. So if your DIP involvement is, it's almost never are rheumatoid arthritis. So the PIP and then the MCP and the wrist, those are the most common. And same in the feet, it could be MTP joint, or it could be IP joint, or it could be ankles. Those are the typical joints that are affected. Now, rheumatoid arthritis is predominantly the articular disease, but it's also a systemic disease. In some of the cases, particularly the seronegative cases, you could have an extra articular manifestation. That could be the eyes, lungs, and some other organs. We will discuss more in the next lecture, but you could have extra articular manifestation. And in general, people who have severe rheumatoid arthritis who are seropositive, meaning rheumatoid factor or CCP positive, they tend to have extra articular manifestations. Now, in case of untreated rheumatoid arthritis, it could eventually lead to joint damage, and it also leads to damage to the ligaments that leads to different type of deformities that you'll be seeing in rheumatoid arthritis. Now, these days, because of so effective treatment, we don't see a lot of deformities because of very effective treatment. But if someone has rheumatoid arthritis that is untreated, you will see a lot of deformities. Now, we'll talk a little more on those deformities. I'll gather some more slides with pictures to describe those deformities, but it is a feature of untreated rheumatoid arthritis. Now, as I mentioned earlier, the typical pattern of joint involvement is the PIP. So that this is your the PIP joint and then the MCP joint and the wrist. Those are the typical features, and almost never the DIPs. Now, you have rheumatoid arthritis on your right side and then the osteoarthritis on your left. If you look at the osteoarthritis, you have DIP involvement, and you don't have involvement of the DIP in rheumatoid arthritis. So DIP is exclusively, it's not rheumatoid arthritis. Typically, it could be osteoarthritis or psoriatic arthritis. Those are the two typical causes of DIP involvement, but not rheumatoid arthritis. Now, in the diagnosis, the further investigation that we typically do is to understand what is the level of inflammation. And then that is typically measured by either ESR or CRP. You could have either elevation of ESR or CRP, or typically both, and that indicates there is ongoing inflammation. And as evidence of autoimmunity, you could have positive rheumatoid factor or positive anti-citrullinated peptide antibodies. And that is present in almost 80% of the patients, and rest 20%, they could have a seronegative rheumatoid arthritis. Now, when we do an X-ray, usually the X-ray stains occur later in the stage of the disease, but typically in the beginning, we do get X-rays in all of our patients. That is as a baseline, so that we can track how is the progress of rheumatoid arthritis down the road when we treat, and this is also used to understand what's the progression of the disease. So the lab, we typically do ESR, CRP, as evidence of autoimmunity, the rheumatoid factor and CCP, and the X-rays to understand whether there are any joint erosion or joint damage. And that typically happens in the later phase. Now, this is an example that describes some of the clinical features. In the panel A, you could see that the joints are quite swollen, and typically you can see the PIP and the metacarpal MCP joints that are pretty swollen. Same is on the other side, and you can see the symmetric distribution of the joint involvement. And the DIP joint is spared. You don't see any swelling in the DIP joint. And if you look at the panel B, this is a case of a more severe rheumatoid arthritis, where you can see the MCP is so swollen, and then you can also see some deformities. This is called a G deformities, and basically that's a sign of a damage to the ligament. So the rheumatoid arthritis do also cause inflammation around the ligaments, and that causes the ligamental laxity, leading to subluxation, and then a lot of other deformities of the joint. Now, similar rheumatoid arthritis you can see in the feet. The panel C is showing a severe rheumatoid arthritis with a lot of deformities, and you have all these different deformities found in the foot joint. Now, the panel H is showing signs, it's called a rheumatoid nodule. That is also a feature of rheumatoid arthritis. Typically, you see in those flexor tendon areas where you typically find the rheumatoid nodule. Now, in the panel G, it is showing it's a CT scan of the neck. One of the rare features, sometimes you could be testing the board, somebody who has rheumatoid arthritis, and they come for surgery, and then they develop spinal cord lesion, and that is one of the classical board question of rheumatoid arthritis. You could have Panus formation in the atlanto-occipital joint. So that's why if somebody have long-standing rheumatoid arthritis, so pre-operative, you need to do X-ray after C-spine to look for that type of atlanto-axial subluxation. That is quite important, but it's a very rare risk with the rheumatoid arthritis. Now in panel D, E, and F, you could see some radiological features of rheumatoid arthritis. The D is a normal joint, and if you look at the panel E, you could see a lot of joint erosion, and you could hardly see any joint space. So there is diffuse joint space loss. That is because of the destruction by rheumatoid arthritis, and same is in other joints. So you have lost the joint space because of rheumatoid arthritis. And in panel F, you could see the joint subluxation. That is because of the joint damage from rheumatoid arthritis. And this is more a feature of late stage rheumatoid arthritis that is not treated. Now, this is, I think, the summary table that explains a little bit more detail the concept of. Now, we discussed this in the pathophysiology section. I'm reiterating it because it's a very important concept to remember in the pathogenesis and the clinical manifestations of rheumatoid arthritis. So, in the beginning, you could see somebody who is susceptible to rheumatoid arthritis. They don't get any signs and symptoms or any signs of autoimmunity. They just have genetic risk factors, and those genetic risk factors account for 60% of the risk. And as we discussed earlier, the genetic risk factor could be a presence of HLA-DRB1. That is one of the common known genetic risk factors. And in the background of genetic risk factors, there is 40% risk with environment. That could include smoking, that could include dysbiosis of microbiome, and female sex is also one of the risk factors. And they even mention about the Western diet. Now, it's a very interesting concept. Now, why diet is related with rheumatoid arthritis, and the thought process is what you eat affect the microbiome in the gut, and the microbiome affect your risk of rheumatoid arthritis. So it's an indirect relationship between diet, microbiome, and rheumatoid arthritis. That is how we link diet with rheumatoid arthritis. Now, it's a well-known fact that diet is important in rheumatoid arthritis, but it's a very difficult topic to study scientifically. That's why we don't have a good understanding which type of diet is good for rheumatoid arthritis. But typically, here in the US, I think there's a concept of anti-inflammatory diet that contains a lot of green leafy vegetables, fruits, whole grains, and then olive oil. Those are some of the common ingredients in the anti-inflammatory diet. Now, back in Nepal, I feel that our diet already contains those things. Like we eat organic, we usually raise most of our vegetables in our garden, fruits in our own garden. So that's why I think those are all organic. So that's why I feel overall the incidence of rheumatoid arthritis is less in Nepal because of our good diet. And then that is changing our microbiome. So we have a healthier microbiome back home in Nepal. That's why I think there is a lesser incidence of rheumatoid arthritis in Nepal. So that is in the susceptibility to rheumatoid arthritis. Now, in the preclinical rheumatoid arthritis, where they could have no symptoms, but when you check antibodies level, they could have autoantibodies production. Now, I show you a graph of time of diagnosis of rheumatoid arthritis, and before you could have antibodies way before your diagnosis. This is where is your early preclinical RA. Now, the next stage is early rheumatoid arthritis, where you start with mild joint pain. And then when you examine the joint, you may not see a lot of signs and symptoms of rheumatoid arthritis, but the patient start with what we call arthralgia. When you examine, you may not see any signs and symptoms, but they start having mild joint pain. That is what we call early rheumatoid arthritis. Now, as the inflammation goes on, then you have established rheumatoid arthritis, where we see all the signs and symptoms of rheumatoid arthritis. Now, I think this is our final slide for today, and this describes some of the classification criteria on how we classify rheumatoid arthritis. Now, this is more important when we talk about research in rheumatoid arthritis. Now, these criteria are basically developed to classify whether somebody has rheumatoid arthritis or not. Sometimes we use this classification criteria to also make the diagnosis, but it's very important that diagnostic criteria is not the same as classification criteria. These classification criteria is to make sure that we get a similar type of people when we do clinical studies. So this is more for we call a homogeneous population. But for clinical purpose, we don't always rely on this test. if you look at the classification criteria, we typically use 2 classification criteria. The older one, the table 70.3, is called the 1987, the American College of Rheumatology classification criteria. This is the older classification criteria that was revised in 2010. On your right side, it is more revised. And the purpose of the revision was to diagnose rheumatoid arthritis early so that we could treat them early. In rheumatoid arthritis, the time is very important. Like when you talk about myocardial infarction, time is money, right? So the same concept in rheumatoid arthritis. The earlier we treat rheumatoid arthritis, the better it is for long term. And the earlier we treat, the less chances of having long-term complications, particularly joint damage. That's why the ACR revised the classification criteria in 2010 to make sure that we diagnose rheumatoid arthritis early. Now, in the older classification criteria, we use morning stiffness, typically lasting for more than 1 hour. You have to have more than 3 joints involved to call this a polyarticular arthritis. And you have to have hand arthritis. Now, you have to have symmetric involvement. You have to have rheumatoid nodules. You have to have serum rheumatoid factor and some radiological changes. One of the problems with this classification criteria is we are waiting for a patient to have some radiological changes, which happens in several years before we make the diagnosis. So we are missing the opportunity to treat this patient early. That's why we don't typically use this older classification criteria, because it's too late when we make the diagnosis. That's why if you look at the right side of the table, now we use a point system. And depending on how many joints you have, whether you have serology positive or not, whether you have ESR, CRP, and even the duration now, it is coming down to less than 6 weeks. Now, they use the time 6 weeks. One of the key reasons why they use the 6 weeks period is there is a form of arthritis which behave very similar to rheumatoid arthritis. It's called viral arthritis, like particularly the parvovirus B19, even hepatitis B or C. They could even cause quite similar type of arthritis like rheumatoid. Typically, those type of viral arthritis, they don't last for more than 6 weeks. So that's why the 6 weeks time period is to make sure that we are not labeling somebody have viral arthritis as rheumatoid arthritis. We use that 6 weeks period. But in the right clinical context, even we don't even wait till 6 weeks before starting medication for rheumatoid arthritis. But at least compared to 1987, the 2010 is a more sensitive diagnostic tool, and then we diagnose quite early before the patient gets changes in their x-rays or they develop other late features of rheumatoid arthritis. Now, you don't need to remember all of these numbers or all of these points, but at least you should remember that you have to have inflammatory arthritis that is symmetric, predominantly involving the joints or the feet, and you have to have some signs of autoimmunity, either rheumatoid factor or the CCP, and then when you do the inflammatory markers, the ESR, CRP, you have to have some elevation of the inflammatory markers to suggest that this is an inflammation problem. I think I will end this with this slide, and then we'll continue in the next lecture. We'll talk more about some of the extra-articular manifestations, and then we'll talk about some of the x-rays, what we see in rheumatoid arthritis, and we'll talk about some of the treatment options. The treatment is a very big topic, so I'll try to modify as much as possible that will be in the right context in Nepal, because a lot of the medication we cannot use in Nepal because of the particularly infectious risk, like TB is quite prevalent, so we don't typically like TNF inhibitors if there's a high TB incidence. We'll talk more on the next topic regarding further on the treatment options. Okay, I hope this was a simplified form, and if you have any, now I know the genetic and then the pathophysiology is sometimes confusing, so if you have any questions, we can go back in the next lecture, a little more detail or any other questions you might have in the pathogenesis.
I have a question. So what is the average age of presentation when they come in?
So typically it's a disease of younger age, usually childbearing age, that is what they usually call, like 20 to 40 years is a typical age of diagnosis. But there is a form of rheumatoid arthritis that is also common in kids. We call juvenile form of arthritis. Now, sometimes we use a called JRA, juvenile rheumatoid arthritis. That is one other, that is a pediatric form of rheumatoid arthritis. And then there is other called late stage rheumatoid arthritis that typically the disease start at age 65 and plus, but typically it is a disease of younger age group.
And what is the prognosis if when diagnosed?
Now, as I mentioned, the prognosis depends on how well the disease is treated, and then there are a few other prognostic factors. Some of the commonly used prognostic factors to call this, whether this is mild, moderate, or severe rheumatoid arthritis, is one is a presence of autoantibodies, typically CCP. If you have high titer autoantibodies, they tend to have more severe disease. And we describe severe disease as those who have erosion. When we do the X-ray, if we have signs of erosive disease, they are we call them a severe disease. And we become more aggressive in treating those patients sooner with aggressive immunosuppressive medication. Now, patients who have more severe disease, they also have more extra-articular manifestation. Rarely, some rheumatoid arthritis patients do have lung involvement with interstitial lung disease is one of those. Eye with inflammatory eye disease is others. And rarely heart myocarditis or pericarditis could be one of the extra-articular manifestations. But the severity, it depends on whether they have presence of autoantibodies and whether they have presence of erosion at the time of diagnosis. Now, early treatment is important to prevent those erosions and then to prevent those extra-articular manifestations.
So you said the myocarditis is very rare. So
it's very rare, yeah.
So is this kind of, so myocarditis and the lung involvements are rare. So is this kind of like a disability, like the patient will continue with the disability instead of like life-threatening conditions where they can die of it?
It's not a life-threatening condition. Rarely it could cause, it's not considered a life-threatening condition unless they have like severe interstitial lung disease where it's untreated, that could lead to, but it's not considered a life-threatening disease. They could have a lot of deformities. That is one of the main problems, but not life-threatening.
Thank you so much, Dr. Ananta, for today's lecture. Thank you, Jagadamba Didi, for this platform. And thank you, everyone, for coming in today. And we'll just end it right here.